3 landmarks are required: the tip of the greater trochanter, the tuberculum innominatum, and the superior anterior iliac crest. Identify the tip of the greater trochanter and the superior anterior iliac crest. Draw a line from the midpoint between the tip of the greater trochanter and the tuberculum innominatum to the antero-superior iliac crest. Define the initial incision. This runs from the border of the trochanter and extends approximately 6 to 8 centimeters along the guideline. It will mark a plane that defines the femoral neck axis. Make an initial skin incision and then divide the fatty layer in line with the incision. Lift the skin and undermine the fatty layer to create a mobile window sufficient to expose the capsule, but not so extensive as to risk necrosis of subcutaneous tissue. The femoral cutaneous nerve is ventral to and well away from the exposure. With the fascia exposed, palpate the underlying plane between the tensor fascia lata and the iliotibial band. It is here that the fascia is of sufficient thickness to allow closure at the end of the procedure. Incise the fascia approximately 2 to 5 millimeters medial to the underlying border of fascia lata, following the direction of skin incision. Use scissors and blunt dissection to separate the tensor fascia lata ventrally from the fascia, following the plane of incision down to the capsule of the femoral neck. Insert a straight Hohmann retractor between the tensor fascia lata and the sartorius muscle, with the tip coming to rest on the femoral neck at the bottom of the greater trochanter. Retract the tensor laterally, together with the abductor minimus and medius muscles. Use a second retractor on the femoral calcar to retract the sartorius and rectus muscles ventrally. This will expose the capsule over the femoral neck. Make a T-shaped capsular incision, inferior to superior, and along the border of the greater trochanter. Lift the capsule away from the bone, using a rasp if necessary. Suture and reflect both flaps, ready for reattachment. Use a long, narrow saw blade to resect the femoral neck in 2 osteotomy lines along the capsule without dislocating the hip. After completing the osteotomy, a chisel is used to flip the femoral neck toward the front. This will allow a corkscrew to be introduced into the femoral head. Follow the central axis of the femoral neck into the head, not into the neck. Turn the corkscrew several times and remove the femoral head. Once the head has been resected and extracted from the wound, turn to the acetabulum and remove any remaining labrum. Put a third double bent retractor beneath the femur and move the femur distally to provide good visualization for acetabular and femoral reaming. Using the smallest reamer attached to the 45-degree driver introduced perpendicular to the table, ream the acetabulum, holding close to the transverse ligament. Once the acetabulum has been deepened to the level determined during preoperative templating, the reamer size is sequentially increased in 1 to 2 millimeter increments. Reaming stops when the socket has become a true hemisphere, and when the reamer makes contact with the anterior and posterior walls of the acetabulum. Following preparation of the acetabulum, a pinnacled trial shell, 1 to 2 millimeters larger in diameter than the last reamer, is attached to the threaded connector of the acetabular inserter. The pinnacled trial shell is introduced to the acetabulum. Appropriate trial shell orientation can be verified with external alignment guides in addition to natural landmarks such as the transverse ligament. The trial is used to assess the coverage of the acetabular component and to gauge the seating depth of the actual cup. The definitive pinnacle acetabular shell is attached to the threaded connector of the acetabular inserter. The shell is introduced into the acetabulum and impacted in place. Remove all soft tissue from the face of the shell so as not to impede liner seating. Prior to inserting the final Ultimate liner, thoroughly irrigate and clean the shell. Select the correct sized liner inserter head and attach it to the acetabular inserter. Final impaction into the pinnacle shell is completed using the acetabular inserter and the correct sized liner inserter head. The leg is then flexed, abducted, externally rotated and placed in a bag. Beginning with the smallest brooch attached to the brooch handle, the medullary cavity is progressively enlarged until the level of the neck resection is reached. The depth of the implant, established during femoral planning, is measured in relation to the greater trochanter using a needle to find the exact height of the greater trochanter. Broaching should continue until complete axial and rotational stability is achieved. The size of each brooch matches the corresponding implant without HA coating. Choose the same size Kurai stem as the last brooch used. The stem is inserted by hand into the femoral canal. The femoral impactor and a small hammer are used to drive the stem into position for the last 1.5 centimeters. Continue driving the stem until the HA coating is no longer visible. The Ultimate femoral head is placed onto the taper, reduce the hip, and perform a final stability check.